Good evening, everyone. I'd like to welcome all the participants to our second live session in the 2021 Congress of the Romanian Society of Lifestyle Medicine. I say good evening, but in reality, I should say good morning, good afternoon, and good evening, because we're being joined from very many corners of the world, and we might be having people from Asia to the States watching us. So wherever you're joining from, we're very happy that you're with us tonight. We're very excited that we can meet with you with the amazing panel that we have lined up for you tonight. And I'd like to actually introduce our panel members. Give me a second to share my PowerPoint with you. Here we go. I'm your moderator tonight. My name is Conrad. I'm Vice President of the Romanian Society of Lifestyle Medicine. I'm a dietitian, a physician, and a lifestyle coach. And for our roundtable discussion tonight, we have some of the best known people from the field of lifestyle medicine. And it's really exciting that we're able to be together with them here in Romania today. I'd like to introduce our first panel member tonight, Dr. Emanuela Mercore-Huțanu. She is the president and founder of the Romanian Society of Lifestyle Medicine and a family doctor. She's also a plant-based nutrition and lifestyle medicine physician, a member of the editorial board of Wiley Lifestyle Medicine Journal, and she's done internships in the USA at the Bernard Medical Center and in Japan in Nagasaki University Hospital. So welcome, Emma. We'd also like to welcome again, because we had Dr. Deal speaking on Sunday night, our keynote speaker, Dr. Hans Deal. He's a lifestyle interventionist, a researcher and author, educator, speaker and presenter, and founder of the world famous CHIP program. The book he is best known for is the one you see here on the slide, Health Power, which he co-authored with Eileen Luddington. And here on the right, you see, to the right of the book, you see the logo of the CHIP program, which is a program for reversing chronic disease that's had over 100,000 patients go through it, which is really amazing because it shows the power of lifestyle medicine. The CHIP program has had dozens of studies published about it, and it's a verified program to help reverse chronic disease. Also joining us tonight is Dr. T. Colin Campbell, or maybe we should say the Colin Campbell. We're very, very happy that we can have practically the largest or the best known researcher in the field of nutrition from the 20th century joining us. And it's just really, I mean, it's so valuable to have so much knowledge, decades of knowledge packed into one man who can share that with us tonight. Dr. Colin Campbell is an iconoclast. He's a researcher with over 300 studies published. He's a nutritionist, an academician, and professor emeritus of Cornell University, which, as you know, is an Ivy League university, and author of multiple books. But the book he's best known for is the China study, which was translated into over 50 languages. And as I have heard, Romanian was actually the first language that the China study was published in or translated into. So that's an honor for us that we can have him here, and that Romania was also the one who took the first step to translating this very important book in nutrition science. Joining us tonight, we also have Dr. Caldwell Esselstyn, and Dr. Esselstyn is also a very well-known physician. He's a surgeon. Maybe some of you know him as being also the doctor who helped treat former President Bill Clinton. He's director of the Cardiovascular Disease Prevention and Reversal Program. He worked at Cleveland Clinic Wellness Institute, and as you guys probably know, Cleveland Clinic is probably the foremost cardiology hospital in the world, or if it's not the foremost, it's one of the foremost for sure. He has over 160 scientific publications, and he's actually an Olympian gold medalist. You know, talking about lifestyle medicine, what better evidence than being an Olympian gold medalist? He's author of Prevent and Reverse Heart Disease. And here I actually have a photo for you of the 1956 Olympics, where Yale's team for rowing, the rowing 8s team, is showed, and Dr. Esselstyn was actually a member of this winning team in the 1956 Olympics. On the right-hand side there, you see the title and the cover photo of his the book he's best known for. We have Dr. Michael Klepper joining us, a very, very popular doctor in America, lifestyle medicine doctor. He's an internal medicine specialist. He's also trained in surgery, anesthesiology, and orthopedics. He's an author and best known for the book Vegan Nutrition, Pure and Simple, a researcher, a lecturer, and educator. He's a lifestyle medicine consultant, a longtime radio host, and also nutrition advisor to NASA. Now that's really interesting. He actually advises NASA for the space colony programs to the moon and Mars, the nutrition side, of course, and he's also an advisor to the nutrition task force of the American Medical Students Association. And we have Dr. John Kelly joining us, who's a preventive medicine physician and an epidemiologist. He's founder and the first president of the American College of Lifestyle Medicine, which is, very important for us in this field, because the American College of Lifestyle Medicine is one of the big forces that's pushing the field of lifestyle medicine forward globally. He's a researcher and educator. He does lifestyle medicine training. He's an author, and he has co-authored the official Lifestyle Medicine Board Review course. Now, I don't know how many of you are familiar with the American medical system, but in order to be allowed to work in the US, you have to be board certified. So obviously, anybody who's writing textbooks for board certification is somebody who has to be a teacher of the teachers. So we're happy to have Dr. Kelly with us, and he's also co-chair of the expert panel of the American College of Lifestyle Medicine. Welcome our panel tonight. Thank you for being with us, for taking time to be with us. And I would actually like to hand over tonight's discussion to Dr. Deal. He will be leading the panel discussion. So if Dr. Deal, you could please unmute your microphone and your camera, then we can start. And I'd like to ask the rest of the participants to unmute your microphones when you would like to talk. In between, if you choose to, you may mute your microphones. Do we have Dr. Deal with us? Not yet. Until Dr. Deal, Daniel, if I could ask you, Daniel is working in the background to help us here. Daniel, if I could ask you to please try and get in touch with Dr. Deal while we get things warmed up, and help me out there. In the meantime, then, I would like to start our panel discussion for tonight. And obviously, we have people from different fields of medicine. Please feel free to add to any topic that we will be discussing tonight, because all of you have your specific perspective on the topics, and this is something that we really need to benefit from. One of the first things that I would like to introduce tonight is the topic of type 2 diabetes. Now, as you guys probably all know, type 2 diabetes is a problem not just in the United States. It's a problem in most of Europe, Australia, in most developing countries. There was something very interesting that was mentioned on Sunday, namely that type 2 diabetes is driven more by fat intake, because most people think of type 2 diabetes as a glucose, as a glycemia problem. Would you be able to give us more information on why is it that fat is actually one of the main drivers of type 2 diabetes? Anybody? Yes, Dr.
Yes,
Dr.
well,
Klepper.
a lot has to do, of course, with the Western diet, and coming from the good old United States of America, we are one of the world's leaders in high-fat diets and fast foods. And when one eats that kind of diet, bacon and eggs for breakfast and a cheeseburger for lunch and fried chicken for dinner, you're keeping fat, saturated, mostly animal fat, in your bloodstream hour after hour, day after day, month after month, year after year. And as time goes by, the fat infiltrates into the muscle cells, into the liver cells, And in the muscle cells, you get what's called intramyocellular lipid, which just means fat in the muscle cell. You can see it if the tissue is properly stained, you can see the fat in the muscle cell. Well, the fat accumulates, it starts to oxidize, and it starts inhibiting the enzymes that insulin requires in order to activate the GLUT4 mechanism to get sugar or glucose from the bloodstream into the muscle cell. If the enzymes and the insulin receptors were all clogged up with fat, then insulin knocks on the door, but nobody answers, and the bloodstream piles up with blood sugar. And people say, aha, high blood sugar, avoid sugar. But it was really the fat in the diet on a large chronic basis that accumulated in the tissues that inhibits the action of insulin. And the good news is, if one goes on a whole food plant-based diet, lots of salads and soups and vegetables, etc., the fat in the muscle cell gets burned for energy. The insulin receptors start working again, and the sugar comes out of the blood into the muscle cells to be burned. And it turns out to be a very reversible disease. I wish someone had told me that in medical school, but type 2 diabetes is eminently reversible, but you got to focus on the fat and go and pull that out, the excess fat, we need a little bit, and go on with those whole plant foods with easily digestible carbohydrates and vitamins and minerals, and the metabolic machine hums along like a fine-tuned sports car. So we're plant-eating creatures, we just need to honor that.
Mm-hmm. Now, before anybody else chimes in, I just want to say something. Not all our listeners are physicians, and you said something about GLUT4. Can either you, Dr. Klepper, or anyone else who wants to explain some of the biochemistry, what is GLUT4 and how does glucose actually enter the cell?
Right. I'm sorry. GLUT4 is the name of some enzymes that are required to allow sugar, glucose, to enter the cells through some specialized area on the surface of the cell membrane, the insulin receptors, and the GLUT4 enzymes help the insulin receptors work. So when the pancreas in our abdomen senses that we've eaten sugar and the blood sugar rises, the pancreas puts out insulin in response, a little protein, and as the insulin goes to the muscle cells, liver cells, it activates some enzymes that allow the sugar to be pulled from the bloodstream into the muscle cells where it can be burned for energy. So we don't want to interfere with that mechanism with excessive amounts of fat, and that's largely the mechanism that drives type 2 diabetes.
Okay, I know from knowing who are some of the participants in Romania. We actually have a specialty called diabetology. I know in many countries in the world, diabetes is included in the field of endocrinology. Now in Romania, we have endocrinology and diabetology separated. And I know I have colleagues who are diabetologists who are following along. And they would probably be quite interested to know, in that case, if I have a diabetic patient who's got type 2 diabetes, and I want to help them, what kind of practical recommendations should I be making in order to help that patient to go on a plant-based diet, but in the first few days and weeks of the transition, not to constantly have hyperglycemic highs in their blood sugar levels? What would I want to recommend? What should a diet recommendation look like then?
I don't want to monopolize the conversation. Dr. Kelly, Dr. Esselstyn, anyone want to jump in? But again, there's nothing too exotic. Breakfast would be, again, we want these high carbohydrate whole foods. So whole, say, steel cut oats with some berries and almond milk for breakfast. Lunches and dinners, big salads, hearty vegetable soups, lots of legume dishes, beans, peas, chickpeas, lentils in various soups and casseroles, etc. Lots of steamed green and yellow vegetables, a whole food plant-based diet. But as you are rightly saying, If this person has been treated for diabetes and is on a significant amount of insulin, you don't want that sugar to go too low in the bloodstream. So as they say, better too sweet than sour. It's always safe to cut the insulin dose in half. You can always add a little bit more insulin, but you don't want them, especially at nighttime, to run into very low blood sugars. And there's a whole art of so-called de-prescribing. Again, another concept I wish someone had mentioned to me in medical school. There's an art to getting your patients off these medications, because the ultimate goal of treating type 2 diabetes is to have the disease reverse, have it resolved completely, so the patient is no longer diabetic, does not need insulin. And everyone here on this panel who's a practitioner we all have dozens and dozens of patients who used to have type 2 diabetes, who lost weight, increased their exercise, improved their diet, and now they handle glucose normally and no longer have need for insulin. They're no longer diabetic. So it's one of the most exciting moments in medicine to watch your patients get off insulin, off their diabetes medications, and leave that disease in their past. It's exciting.
Yes, thank you. Thank you. If you'd, I'd have a couple of thoughts to share here, Conrad. I appreciate appreciate Dr. Clapper's comments. I just want to point out a couple of things. One is that I remember the first time I saw published in a really credible journal the words diabetes and reversal in the title, and it got my full attention. That was by Lim et al. Out of Roy Taylor's lab in the UK. And they showed the normalization of blood sugar, fasting blood sugar, in the first week of the study. They were using a very low energy diet with a meal substitute, which we believe that's not the necessary, but it certainly works. But what I want to point out is that in their work, and they've also they're in the middle of I think the third year of the DIRECT trial, which is they took that same approach and put it into the public health system there in the UK. They take the people off of all insulin and blood pressure medications to start the intervention because it is so powerful. It's safer actually to have the numbers run a little high, as Dr. Clapper was saying, than to jeopardize the patient having a hypoglycemic episode. But they take the patients off of those medications for safety reasons, and then in the following that week, they may put some medication on board as necessary depending on the patient's degree of response to the therapy. So we don't have, as far as I'm aware, we don't have the kind of randomized trials or studies we are in the process of getting using whole food plant diet the way that Taylor's group have studied the meal substitute. But we have anecdotal evidence, we have observational, and many of us, like myself and Clapper and others on this call, who do treat diabetics with lifestyle and with plant diet, we know from experience that we have to cut the medications at least in half, as he said, and oftentimes I just cut all insulin and just perhaps leave metformin on board or something like that nature. Because after all, you have time to, in an intensive intervention, you have time to observe what's going on with the patient. We monitor their blood sugars 5-6 times a day, et cetera, and manage it very carefully. Anyway, I just wanted to throw in that fact that the danger of when you use an intensive lifestyle intervention, it is so powerful that the danger is of over medication, not under medication.
Thank you very much for that. In the meantime, I see that Dr. Deal's joined us, so I'm going to hand the mic over to Dr. Deal, and he will moderate the rest of the session.
Oh, we're right in the midst of things. I wanted to actually make a statement before we officially start this now. First of all, I want to thank Conrad for introducing our venerable panel members. These are titans in the scientific, the educational, and medical fields. Can you hear me and see me? Is everything okay?
Everything's good.
Okay, very, very good. It took some time. Welcome to the panel. Many of you are my friends, and I feel very, very honored that we can work together in trying to reach this kind of a concept into the world of Romania. I am also very, very indebted to Emanuela as the chair lady and the president of the Romanian Society for Lifestyle Medicine in putting this program on as an inaugurational event of trying to introduce concepts that can make a lot of difference in how we structure our health and our lifestyle in Romania. Here's my introductory statement that I wanted to read to you. We recognize, quite frankly, that the modern medical science, with all its technology, has really little to offer in providing effective cures for chronic diseases that are largely circulation related. On the other hand, the new board-certified medical specialty of lifestyle medicine has utilized the studies and science to make the scientific evidence more prominently known among the medical profession. Strong data going back to Lester Morris in 1958 and Nathan Pritikin in the 1980s has been published in some of the best medical journals. The Pritikin group alone published more than 120 peer-reviewed articles in prominent medical journals. And then Dr. Colville-Esselstyn and Dr. Dean Ornish turned the medical world upside down by demonstrating angiographically that coronary artery disease is subject to regression and reversibility through a lifestyle medicine approach, focusing on a very simple diet of foods as grown. And so here are some of my questions. Why has it taken the medical profession so long to get interested in embracing the clinical results of some of these prominent studies published in the Journal of the American Medical Association, in the Lancet Medical Journal, and the American College of Cardiology? Why has it taken so long for the medical profession, our colleagues, to begin to embrace these kind of concepts that can provide health and disease, reversal?
I'd like to try to tackle that one.
Okay.
I think for years, we used to say that it was a lack of getting the word out. It was a lack of perhaps education of cardiovascular medicine, the fact that it wasn't being taught in medical schools. But as my friend Kim Williams has said, there are two types of physicians: those who have or who are plant-based and those who have not read the literature. So the information is out there, but I'd like to take it a step further today, because when we get the United States government, United States Department of Agriculture, every 5 years, will make a suggestion for the public as to what is the food plate or the pyramid of food that is best for their health. And it's not surprising that when this comes out, who are the people that put it together? The leaders on the United States Department of Agriculture. Well, who are they? They have all formerly been a former president of the Beef Council, the Dairymen's Association, Mars Corporation, the Pork Board, the Egg Board. They are enormously conflicted. So when you tell the population of the United States every 5 years to eat foods that are going to actually injure them, that's really going to slow down the progress. Now, the other thing that I've recently had an interest in is, who are the two leading cardiovascular associations in the United States? The American Heart Association and the American College of Cardiology. So let's see if there are any conflicts there. Remember, they have 88,000 members worldwide. Well, who are the sponsors of the American Heart Association? I just happen to have a little list here that you might be interested in these sponsors. How about the Nebraska Beef Council, the Colorado Beef Council, the Idaho Beef Council, the Texas Beef Council, South Dakota Beef Council, and also Domino's Pizza, Kraft's, Kellogg, Pepsi. I mean, the list goes on and on. This is an enormous conflict. That's the American Heart Association. What about the American College of Cardiology? Well, Boston Scientific, General Mills, GlaxoSmithKline, I mean, we've really got to answer to this challenge. So anyway, this is just a little bit of piece of information that I wanted to put out because I think it really represents an enormous glaring conflict. Because let's look at the dietary recommendations of these organizations. These are the leading cardiovascular organizations in the United States. What are their dietary recommendations? Well, vegetables, fruits, and legumes. Well, and that's pretty good so far. But then poultry, dairy products, fish, oils, sweet, sugar-sweetened beverages, and meat, all of which are going to create cardiovascular disease. They're going to injure the endothelium. The endothelium is not going to be able to make nitric oxide. And then we get to cardiovascular disease, which is a nitric oxide deficiency disease. That's as far as I want to go with that.
Well, these are colossal forces that are really highly conflicted, isn't it? Anybody else?
Yes, I would like to appreciate Dr. Esselstyn's comments for sure. You know, something that sort of backs that up is look at the Philippine College of Lifestyle Medicine. They have adopted lifestyle medicine much more quickly, Dr. Deal, than has happened in the US and in Europe. Perhaps Lithuania is an exception in Europe, but the Philippines have already gotten ahead of us. They are starting to certify lifestyle medicine physicians at a higher per capita even than the US and Europe. And they are introducing lifestyle training into medical training. I mean, so I'm sure you're aware, even better than I am, of what's going on over there. But it is, I think, the European, the US and Europe are the ones that have been so slow, I would say. Many of the other countries are making faster progress with lifestyle medicine.
Yeah, you mentioned Lithuania. Things are happening in Lithuania, but it took about 6-7 years where we now have a master's degree in lifestyle medicine, and the new graduates are becoming really integrated into the new concepts that are beginning to mushroom. So we're very, very excited about this. So we know that change can take place, but it's easier in smaller countries than in the United States, right? I mean, you have major economic forces there. Anybody else?
Yeah, I would like to make a comment if I can. I'm the non-clinician in the group, of course, but so my interest and experience have been in the basic science. And I would like to suggest that nutrition has been really, quite frankly, quite confusing for most people. And my own profession has been leading that problem. We tend to focus on two ideas that I think are really paramount from a historical point of view. Namely, we tend to almost, I hate to use this word, worship protein, especially protein coming from animal sources. Many people for many years believed protein only came from animal sources. We know that's not true, but nonetheless, the protein from animal sources was considered high quality. That is a myth. That is a myth because the way it's actually measured in research, the high quality means the percent of the protein consumed that's actually retained by the body. We call it biological value. And that was premised on the assumption that it gave more rapid growth rates, which a lot of people like to hear. But now we know that numerator that they've now retained is actually also reflects a synthesis of growth hormone. It reflects the elevation of blood cholesterol, as we can see in heart disease. It reflects the production of free radicals, which we can get from all sorts of things. So our interest with protein has been a problem. That's number one. That's really influenced the field in a great deal. I think the second thing that also now in a more recent time, maybe not so recent, is our focus on one nutrient at a time. Again, coming back to my own profession, nutritional science, we discovered, single nutrients like vitamins and so forth that could operate in that way. And in reality, there's two ways to think about this question scientifically. One is to talk about the details, the specific nutrients, the specific mechanisms, specific treatments, if you will. That's one way. That creates a lot of confusion, in my estimation. In contrast, the other way, and this is where lifestyle medicine really becomes a very prominent idea, namely, these things work together. We can see that inside of cells, inside of the activity, or inside of metabolic sequences and that sort of thing. The interrelationships of these immense numbers of nutrients, the immense numbers of mechanisms, the immense numbers of the breadth of the disease. We're talking about something that I would call whole. I'd like to call it that. It's the whole is greater than the sum of its parts. So I want to throw that out here, that so that I find that in medicine, if you will, in the clinical medicine, we want to focus on very specific ideas as to what causes what. And in science, we tend to want to work that out and determine what the mechanism is. But in reality, it's a constellation of all this stuff working together. And it just turns out the best formula for that, these things come from plants. It's very simple. And the only reason we've sort of worshipped protein in a sense, and the fact that it comes from animal foods is because it's high quality, which is not true. So 2 ideas. Don't eat, we need protein, obviously, very important nutrient, but we don't need to get it from animals, number 1. And number 2, let's eat whole foods. I know my colleagues here have already mentioned most of this, in a sense that, but those 2 ideas, I would say, can help us unravel the enormous confusion that's extant in this field, and has been so for decades, if not, in fact, for more than a century. And I think this is the template in many ways for lifestyle medicine. It's the whole thing sort of working together in so many different ways. And so we can get out of the business of talking about details. I think we've made some progress.
May I say something as well? To do with the high quality proteins, I think back to the days when I was a student as a dietitian, and that's exactly also what you hear at university level upwards. It's the high quality protein, and what people don't realize is the fact that you have to know what the definition of the term is, because generally the term high quality would induce, in your thinking, also high quality health. But high quality protein is not equal with high quality health. High quality protein is a biochemical and maybe also partly an agricultural term referring to the proportion of amino acids in a protein. It's got nothing to do with health.
Yeah, thank you very much. So we're talking about why is the medical profession taking so long to embracing these concepts when you can see the clinical improvements with chronic diseases within weeks, right? And we talked about that the guidelines that are being given out nationally are usually oftentimes coming from bodies where many of the members are highly conflicted and where economic interests can play a major role, right? We also mentioned now with Dr. Campbell talk about there's a confusion there about protein, and protein has sort of a high view. It's considered to be of primary importance for good health, and we begin to question that now. Dr. Esselstyn.
No, I just was one thing that we've probably been sort of dancing around, which is also very important. And for years I've hesitated to say this, but I think the data are pretty clear. Even the individual practitioners of cardiology, I think, are conflicted because, look, when you do a stent or when you do coronary artery bypass surgery, there is an enormous financial reward as compared to talking to a patient about Brussels sprouts and broccoli.
Yes. Now, that's a pretty touchy subject now, isn't it?
So what? Why not?
Which part, stents or the broccoli?
Well, having worked for a while in the Blue Cross and Blue Shield health insurance field before I became a physician, let me tell you that the payment mechanism was designed around paying physicians for procedures that they perform. And I mean, it's completely understandable. We don't, no one has suggested that there's nefarious motives. And what I'm trying to point out is that it's just the way the system evolved, at least in the US and also in Europe. I think there was this reimbursing doctors for what they did. But now, as you've just pointed out in a humorous way, really we're finding out that the procedures for chronic disease, that's not the right solution. We've got to be, instead of waiting for the disease to get so serious, we have to do an intervention. Let's use lifestyle change to optimize health and minimize disease severe enough to need a procedure. And the payment system has not kept up with that. Where, I mean, I've been a lifestyle medicine specialist ever since I, became a physician. That's almost 20 years. And I have hardly ever gotten paid by a payer, a third-party payer for what I do. I have to rely on the patient to pay me.
Yeah. Well, of course, it's also difficult to document that you have done some nutritional lifestyle counseling, right? When you have a procedure, well, you check it off. It's easy to find the basis there for reimbursement. And maybe reimbursement is actually driving the behaviors of the medical profession.
Right.
May I just, if we're talking about a checkbox that you have to prove you've done something, wouldn't it be most logical then to introduce some programs that are standardized, that can be, they have a standardized foundation which can then be personalized to the needs of the patient. And if the patient's gone through it, be it an 8-week program or a 3-month program or whatever, then you can check the box. You still have a box to check and you can prove you did it.
And if I may say this, this is now happening with our CHIP program, which is a comprehensive health improvement program, where you actually have about 32 hours of instruction. And yeah, you can check it off. You check off the box. And there are now insurance companies that are reimbursing the checked little box. And they do it very, very well because they realize that you can actually make a significant contribution in reversing diabetes through these group processes, 10-week programs. You can do a lot of work in terms of reducing high blood pressure, and physicians have to reduce the medication. Otherwise, the people become too hypotensive. And the same thing is true with angina. Now, Dr. Esselstyn, you have been working in this field more than anybody else. You have seen angina changes fairly rapidly in treating patients with just a simple diet, right?
Oh, yes, that's just really I think the way that I use the term, the way I can throw the hook and I get the patient to become compliant, especially those who do have some form of angina. Because literally, often within 6, 8, or 10 days, if they formerly had to walk 2 blocks before they got chest pressure, now they have to walk 4 to 6 blocks before they get it. They suddenly recognize that they themselves have now become the locus of control to destroy their disease. It's not up to the doctor. They realize that their plant-based nutrition is what is doing this. And that is so empowering to have them maintain the course and continue the plant-based diet. The other,
it's very tempting to think that you can change the topography, the architecture of the inside of the coronary artery in just a few weeks, but that doesn't work that way.
No,
I think what we see is that you're changing the blood viscosity within days and moving into a very low-fat plant-based diet, right?
Well, I think actually, Hans, that's certainly one of the things that I think is happening so rapidly is we're not changing the volume of the obstruction or the plaque within 6 or 8 days. But what we are changing, when we first see these patients, their endothelial cells are so beat up, they're hardly producing any real nitric oxide, the vasodilator. And most important of all, when you think about, I've checked with our cardiovascular pathologist about what happens to the coronary vessel when they dive into the heart muscle. because I have this beautiful slide that shows without any muscle, all these wonderful vessels. And of course, when they start diving into the heart muscle where they're supposed to go, you have thousands and thousands and thousands of interconnecting small intramuscular arteries. And when we first see those patients, the reason their angina is so bad, all of those vessels never have plaque in them. They do not have plaque in the intramuscular part of the coronary artery. But what they are, all those arteries are now vasoconstricted because the injured endothelium is now your enemy and is making two molecules, endothelin and thromboxane, which are vasoconstrictors. So this entire intramuscular coronary tree is vasoconstricted. But as soon as you start this diet and the endothelial cells recover, they start making more vasodilator of nitric oxide, and they stop making the vasoconstrictors of endothelin and thromboxane, which I think accounts for this rapid transition. But we have shown reversal. We have shown reversal not only with angiograms, but we've shown it with ultrasound, we've shown it with pulse volume, and we've shown it with PET scans. So there are multiple ways you can show disease reversal.
Well, it's still puzzling to me with all the new evidence that has been accumulating, especially with regard to the endothelial function there and the vasoconstriction and dilation. Why is it that the medical profession is so reserved in embracing these concepts? I mean, we wanted to be healers. We wanted to create health.
Ask Colin Campbell, when have these cardiovascular professionals ever learned how to talk to patients about nutrition? If you're going to get a lifestyle change, you've got to show a patient respect. The only way to show a patient respect is to give them your time. If you're going to see patients over a 10 or 15-minute period without the spouse, if you think you're going to get a lifestyle change, you have been smoking something. That doesn't work. You've really got to spend some time with the patient. Our bishop, when I run our seminar, it's a single-day seminar for no more than 18 or 20 patients. It's 5.5 hours. How many cardiologists will spend 5.5 hours with their patients? Why? I need them to understand the science, the practicality of food acquisition, and we always have one or two patients who give a sparkling testimonial.
Can I ask a question here of my colleagues here in the clinic area? I was really impressed, Dr. Deal, by your comment on the checkbox idea. I've had the impression, and please correct me if I'm off base on this, but I've had the impression that for physicians to get adequately compensated, they have to work through a checkbox kind of system, if you will, known sometimes as medical specialties, if I'm not mistaken. And so we have all kinds of medical specialties. Everybody can check off an item or a condition or a disease that they may have considered and in working with their patients, but there's no box. Going back to what Dr. Deals has said, I see there's no box available, just nutrition, let's say. So, does this inhibit reimbursement for physicians that they can't check something like that and get appropriate reimbursement either from, I'm speaking of course an American experience in this case, but either from the private sector or from the government sector? Can somebody tell me where I'm off based on that?
Well, I mean, if you had Dr. Ornish here, he would tell you that reimbursement drives behaviors of physicians.
Right. That's what I'm referring to.
And it's understandable in a way, right? But we need to go beyond this somehow. We need to change the reimbursement qualifications, and that's why I think Dr. Conrad's checkbox situation was a very great idea.
Can I just ask you if you could, in a very short amount of time, explain how the American reimbursement system works? Because I'm just concerned that some of our listeners might not know. In Romania, many doctors have a fixed wage, and you can check 200 boxes. You can check 500 if you want, because your fixed wage is still going to be a fixed wage. Now that that's in the public sector, and there might be some differences in the private sector. But I'm just concerned that not everyone understands how the American system works. So can you please explain very quickly what this reimbursement means?
Who wants to provide an
You
answer?
want to do that? You want to do that, Hans? Or you?
Microphone is
No,
on.
go ahead. Go ahead.
All right. So very briefly, in the U.S., we have grown up with a system of health insurance. So these companies are like Blue Cross and Blue Shield is one of the prominent ones, Travelers, different ones. They offer health insurance where the patients pay a monthly premium. And it's like any kind of insurance, more or less, life insurance, similar. And when you have this insurance, it covers payment to the doctor or whoever provides services that you need for medical care. However, the whole system has gotten quite complicated because as technology has increased, the cost of procedures have gone up, and these health insurance companies' income has perhaps declined. So they're trying to find ways to control the services. So they negotiate discounts, etc. So anytime there's this kind of a situation, there will be lots and lots of administrative overhead. I was just talking with a physician, for example, in the US here, 2 physicians in the last week. Both of them are spending more time and money. Listen, this is how bad it is in America. More time and money billing and getting paid for services than they are actually providing care. This one office I just visited 2 days ago, they have 3 people in the office working on the paperwork for billing, etc., and 1 doctor. So seeing patients. So, America's system has gone to where it's in deep trouble. And lifestyle medicine, I believe, has just been one of the things that has pointed out how serious the problems are. So anyway, I think that's enough to get the sense of how things work in the U.S. There are other countries I'm aware of that use a fixed salary, and I think that actually is a much better. And I think lifestyle medicine will rise to the top more quickly in that setting.
What I've seen more and more in the last few months, and I was pleasantly surprised, I can almost say years, is that more and more physicians, when they give their discharge papers with recommendations to patients, are writing dietetic counseling. So they're not providing it, but they're sending their patients to see a dietitian.
Let me ask you this. If you have a colossal conflicted medical system, does that not also include the dietitians? Is the Dietetic Association immune to some of these encroachments of sponsoring agencies affecting the curriculum of dietetics and the teaching, the policies for reimbursement? So even if you're a physician and you write down see a dietitian, how can you be sure that the dietitian has the right answers?
Is this addressed to me about the Romanian system, or is this for everyone? This question
could be for everybody.
Can I make a comment on that? The dietitian idea, of course, is pretty closely related to the nutrition studies idea. Basically, the American Association, the American Dietetic Association, now named the Academy for Nutrition Dietetics. But in any case, we have a supreme body in this country that basically controls the kind of education that dietitians get. I mean, we've actually had to live with that at Cornell University, where we offer a program for dietitians, above and beyond their undergraduate training. So in any case, this organization, AND, however you want to call it, they're very, very powerful. And I've spoken, I think, 3 times over the years as a keynote speaker to that conference. The last time I went there, and I don't think I'll go back, they'll not have me back again. On the registration bag, they had advertised their chief sponsors, the National Dairy Council, M&M Mars, the candy company, GlaxoSmithKline, I'm being very specific here, and some others. So there they were emboldened in a sense to really advertise who they really were. I've seen the same thing too in the curriculum that is offered at universities. They in turn control the ADA, if I use that term, they control the kind of curriculum that is offered at universities who offer the degree in registered dietetics, if you will. So the dietetics are wonderful people. I love them. They're very dedicated people, but they're living within a tent that controls their education. And then in turn, at the national level, if you will, when they have conferences, again, it's pretty much controlled. Let me show you. There's a subsection that sort of devotes their time to vegetarianism, if you will, but largely the dietetic organization, the institution of dietetics, is representing, as Dr. Esselstyn said before, I think as you said it really well, it's representing the same forces that operate on all of us, whether we are patients, whether we are clinicians, whether we are researchers, whatever. And it operates with a firm grip at the national level, at least in the United States. I think, as you covered that really quite well, there's just serious conflicts of interest in this system. And we've got to look at that from that, I think, broad perspective.
Yes, if I might, I'd just like to pipe in as a clinician. I cannot just refer a patient to a dietitian. I have to select the dietitians that will teach and support the interventions that I'm prescribing as a physician.
I don't even trust, I must confess, I don't even trust those because that's why I do it myself.
Fortunately, if you do a search on plant-based dietitians, you're starting to see more and more of them who are specializing in plant-based dietetics because they like to see their patients get healthy as well. The American medical system at this point is a case study on how not to run a medical system if you want to keep your people healthy. It's a child of the 1920s where most people worked on farms, and if you broke your arm, you went to the family doc, and he would set your fracture, and you'd pay him. And you know, an event would happen, a procedure would get done, and payment would be made. And unfortunately, we've taken that right into the 21st century, where most people are inflicting their own diseases upon themselves with their diet and their lifestyle. And we're seeing an epidemic of obesity and clogged arteries, hypertension, inflammatory diseases that do not lend themselves to that old model. There's plenty of money in the system. The insurance companies are paying for these procedures, the bypasses and the stents, et cetera, after the disease is already manifest. But we need to, like Dr. Deal said, turn this on its head and start paying doctors for keeping people healthy. There's value to the community for every CEO that doesn't go down with a heart attack. There's value to the community for every young breadwinner who doesn't get a colon cancer. They and their employees keep working, keep paying taxes. That true wealth needs to be crystallized and taken advantage of, and pay the patient, pay the doctor for staying healthy. There are value-based systems to reward healthy diet and lifestyle, and that's what the ACLM, the Romanian College as well, we're all standing yelling loudly, healthy diet and lifestyles. Let's pay the doctors and the whole health care system for helping that transition to happen among the general population. It's a matter of education and creative financing. Can be done past time that it happens. Do not emulate the current American model of medical reimbursement here. It really perpetuates the disease model, and that's so 20th century. You know, it's time to move on. Dr. Esselstyn?
Hans, I'd like to take this moment to really share with the group and the audience the title of a book, which is really Disease Reversal Hope. I've been asked to write a preface to this book, and it was written by Dan Purgis and Dr. Scott Stowe. And the reason this is going to be an absolute revolutionary presentation is that they have taken examples of persons who have been afflicted with the common chronic illnesses. Let's talk about heart disease, diabetes, hypertension, Crohn's disease, ulcerative colitis, rheumatoid arthritis, lupus, multiple sclerosis, allergies, and asthma. They have taken these beautiful stories that where the patients themselves have been the authors of these stories, and they have conveyed how they came down with the illness, how they were mismanaged by standard medicine, and how, as they evolved into plant-based nutrition, how their disease went away. It is so powerful to hear these testimonials from each of these. I think there's some 34 stories there. And it's actually been my privilege to write the preface to this, but it really does have the potential to have an enormous impact, I think, on this whole problem of really properly treating illness.
Yeah, these case studies are very, very inspirational, aren't they? And they help in motivating people, inspire people to make some of these necessary behavioral changes. Oftentimes, some physicians sometimes call me up and they say, "Can you give a preventive lecture for the community, for the whole community?" And I said, "Why would I want to do this? I'm only antagonizing people. Don't eat any more M&Ms, don't eat any more Oreos, don't drink milk." It only antagonizes people. And I said to this physician, "I'm sorry, I don't think that this is a good idea." And he said, "How do you change people then?" Well, I said, "You have to change the habits. That's how you change the health level. It takes 21 days, 30 days of repeated activity to create a habit. Once a habit is established, it's not really that difficult anymore. Then you just have a maintenance program. But I think it's the initial energy that you need to get over that hump and to actually say, like you said earlier, with angina pain, it becomes, as it becomes less within 3, 4, 5, 6, 7 days, that becomes a motivating force. With diabetics, it's easy to change diabetics. I mean, diabetics are easily making the dietary changes because they take their blood sugar every day. And within 3 days, they will see that the blood sugar drops, and the physician then has to reduce the insulin or the medication. But oftentimes they don't understand. And they say, "Well, how come you're hypoglycemic? You change your diet?" "Yes." "Oh, just eat meat again, get the fat into the system, and then you don't have to worry about the change in your feelings." The idea that it may be the overdosed medication use hasn't even entered yet their minds. And that's why I think we need to really start this program in medical schools. And I really wanted to pass that point on to Dr. Clapper. Michael, you have done something most unusual. Tell us a little bit about why you are doing what you're doing now.
Well, I realize that we're graduating class after class of young physicians who have no idea that they're treating patients. We're making themselves sick on a daily basis from what they're eating. We just blow right past nutrition. We practice medicine like what our patients are eating has no effect on these diseases they bring to us to treat. And so I've been going to the medical schools and trying to reach the first, second, and third year medical students, showing them the effect of what a fast food diet actually does to their patients' arteries, their hormones, their diabetes risk, etc. And not subtly saying, before you order a $1,000 scan and another $500 lab test, stop. Ask the patient what they ate yesterday. And if it's full of burgers and buffalo wings and pepperoni pizzas, that's why they're sitting in front of you, doctor, overweight, hypertensive, clogged up, diabetic, and inflamed from what they're running through their system every few hours. And unless you deal with that, then you're just going to be treating symptoms. If you're just seeing them to raise their metformin doses and raise their beta blocker doses and come back in a month, you'll leave medicine. You want to heal these patients, or don't you? I mean, why did you go into medicine? You want to heal them, then get real about why they're sitting in front of you. It's from what they're eating. But it's cultural. We can't ask about that. Yes, doctor, you must ask about it if you want to really heal your patients.
Yeah. We don't even look at and report the level of weight of patients because we don't want to make them feel uncomfortable. You're obese. You're very obese. You're morbidly obese. No. This is not politically correct, right? Now, so your work with medical students, this is then always at the invitation of one of the deans of the medical school to come in?
No, it's the invitation of the students themselves. The deans, they don't want to hear about this. This is very threatening to their message, to their economy. No, fortunately, in the 21st century, in every medical school class now, there's 20 or 30 students who've seen movies like Forks Over Knives, What the Health, Conspiracy. They've read Dr. Esselstyn's book. They've read the China study. The light is on. And they already are starting lifestyle medicine interest groups, LMIGs, in the various classes. And it's the leader of the LMIG, the Lifestyle Medicine Interest Group, that extends the invitation. They arrange the meeting. They arrange the Zoom connection, etc. I've been doing it largely electronically now, but the students are hungry, pun intended, for this knowledge. And so we've been going right to them, and the response we've been getting is tremendous. They're so appreciative for this information.
So we're not really dealing with the actual, the causes, but we're just doing what we can do after the fact. And I wanted to pass a question on to Dr. Esselstyn. He mentioned to me some time ago that cardiology, largely with its emphasis on high-tech interventions, has become more and more involved in palliative care. We're not reversing the disease, we're not healing people, we're just taking care of them as they are on their last leg. Dr. Esselstyn, I thought when you used that word, cardiology has become more and more palliative. I thought these were some pretty hard words. Can you maybe explain why you use those words, palliative care?
Well, it's simple because a cardiovascular disease is a chronic illness. And let's just take the example of any patient who has cardiovascular disease is given a specific cocktail of drugs that they're supposed to take to do what? To treat their symptoms. And also they are, if it's an emergency, there's every reason to justify something like a stent or maybe even a bypass. However, there are really an interesting number of studies. Orbita in the United Kingdom, the Courage study in this country, and ischemia. What do they show us? Now, in the elective situation of somebody who has ischemia, when you look at three different approaches, let's say it's optimal medical therapy plus bypass surgery. Number two, optimal medical therapy plus stents. Number three, optimal medical therapy alone. At the end of 5 years, major cardiac events between the three groups, no difference.
No, this is for stable angina, right?
But with all due candor, what they call the optimal medical diet to me is a disgrace. I mean, where are the patients totally eating plant-based? They're eating plenty of green leafy vegetables. They're not having, and they've done that for 5 years. No, it's really, but it's a reflection of really how what we are doing today is we're just sort of treating symptoms. But the thing that I think is interesting is when you look at all these chronic diseases that I've been mentioning earlier, the cause is not being treated. That is why this book is so successful. That is why we're so successful with our cardiovascular patients. We're treating the causation of illness. And really, when you think about it, since the days of Hippocrates, there's been a basic covenant of trust between the caregiver and the patient that whenever possible, the caregiver will share with the patient what is the causation of the illness. But sadly today, in cardiovascular disease and most of chronic illness, that is not being done.
Yeah. how can we bring these things into medical schools when the medical schools are also beholden to interest groups? You know, like Dr. Clapper, he has to go under the radar. He has to find those special interest cells of medical students, and then they become, I guess, the new distribution system for raising some questions, right? Now, I talked to the dean here where I am involved, and I said, why don't we bring nutrition into the curriculum? And the answer was very simple. We're teaching medical facts here to pass the national boards in 2 and 4 years. We're training people to pass the test, and there are no questions in nutrition. So why should we spend time in teaching something when they're already jammed full with facts and figures that they have to remember? Do you want to add an extra year? What are we going to do with this? Dr. Kelly, you seem to be nodding. What do you think we can do?
You speak to, no, Kelly, okay.
Oh, no.
No, go ahead, Dr.
No, I'm just going to make a wisecrack at this. I was in a bookstore at a medical school on one occasion, and there was a little how-to prep kind of book for medical students to take their boards, and there was a section on nutrition. So I took the test and I failed.
Who writes the questions, right?
That's right.
Who writes the question? And as a matter of fact, there is hardly any nutrition question on the test to speak of, right? And if there are some, then you, as you said, Dr. Campbell, who wrote the question? Now, Dr. Kelly, aren't you working, isn't the American College of Lifestyle Medicine working closely with the nutrition, the board of the national board to introduce clinical nutritional questions?
Yes. So not me so much, although I support it, but the American College of Lifestyle Medicine is indeed working to bring more lifestyle medicine. I mean, nutrition is center in the practice of lifestyle medicine. I want to acknowledge that, but we're actually taking a broader perspective. We're trying to bring questions to the boards that will be supportive of the knowledge that would make a physician capable of recognizing lifestyle disease, of treating it, prescribing it, supporting it. And so, but this is a slow process, but it is, yes, we are definitely providing input. And the good news is that that there is interest there, you know, where it's not falling on completely deaf ears. But I mean, I remember when I was headed into medical school, my younger sister had actually finished medical school before me. And so I had an inside track. And what she told me was she was valedictorian of her class. So this is a smart girl and in medical school. And she told me, you will never be able to learn everything that they present. You just need to try and survive. It's like a fire hydrant, you know, you to survive in front of a fire hydrant, you don't try to drink it all. You try to keep from drowning. So there's already more in the medical curriculum than you know a reasonable person can completely master. So what we have to do is, as the dean was saying to you, Dr. Deal, we can't add another year. We've got to find out though the things that we're teaching that are not needed. I mean, I can tell you a number of conditions that I learned about in medical school I've never seen and probably never will see. And maybe it would have been more useful to teach me about lifestyle than teach me about these diseases that no doctor practically ever sees right now.
Yeah.
Conrad?
I think Dr. Campbell wanted to say something first.
No,
No, okay. Actually, what I noticed is, I don't know how it is exactly in the American system. In Europe and in Romania, for example, biochemistry is taught very, very early on in medical education. I have very many colleagues who studied biochemistry in first year of medical school, and they just didn't know what to do with it. It just seemed so abstract. And because I did my bachelor's in dietetics before I went to medical school, I already did biochemistry at dietetics. And second time when I did it at medical school, it seemed extremely relevant to me. I was so happy I did it the second time, because when I looked at biochemistry through the lens of nutrition, then it made sense why I should learn the Krebs cycle, why I should learn about beta oxidation. How am I going to explain to my patients, for example, how a triglyceride is broken down into a fatty acid, and the fatty acid is metabolized through beta oxidation, inserted into the Krebs cycle, and so many other things which really turned everything into such relevant information. Or why is it that certain amino acids will be turned into ketones while others will be used for gluconeogenesis, for example. And I think one of the keys to making part of medical school, especially in the early years, far more relevant is just link it with diet, because it suddenly turns into such a logical and understandable thing, and you retain it much easier too.
Dr. Campbell, you addressed in your books the issue of nutritional reductionism, right? You pointed out that in the early days, we were dealing with deficiency diseases, and we found the missing ingredient, the vitamin, the mineral, and we said, aha, this is the problem. And we have extended that kind of a understanding into the chronic disease area, and we're still doing the same thing there, instead of perhaps looking more at the relationship between a nutritional symphony and the relationship to chronic disease. It's not just one ingredient, but it's the totality of all the nutrients that you have been talking about. Can you make some comments on that?
Yeah, I made some comments before, Hans, but in any case, I got interested in that question from a historical perspective, in a sense. So I went back and had to sort of look up some history on nutrition and on cancer in my case. And I found something interesting in the 1800s. And this is an idea that was debated actually in very serious sessions at the time. Namely, they were talking about, for example, the causes of cancer. And the one view was that cancer was nothing more than a local disease. We could cut it out. I mean, that was the point of view of the surgeons. The alternative view was that it's a constitutional disease, they called it. And that come from the 1700s, by the way. The constitutional disease. That in turn sort of spoke to, obviously, what the word indicates, a much more holistic proposition, if you will. And so as the ages unfolded from the middle 1800s onwards, even though that was a lively debate at the time, the constitutional idea sort of went, it almost disappeared. Because then we had radiation, for example, in the case of cancer. We could shoot rays of beams of radiation. We could take chemicals and we could start a chemotherapy industry. And we can start to treat disease, by looking at one thing at a time, one mechanism, taking one thing. And then finally, when the nutrition age came along in the teens and 20s, quite frankly, it was all about, finding the nutrient that could attack this disease, maybe by this mechanism. So there the groundwork was laid. That's what we became. And so, as I'm sad to say, in my community too, we tend to look at one thing at a time, and that's what gets published. And that's what we get funded for, to look at it that way. I find it extremely frustrating, to be honest about it, because there is this other view when you look at all the nutrients together and from inside the cell, and biochemistry is my territory in a sense. I was absolutely amazed at a point in time when the numbers of nutrients and nutrient-like substances in food are innumerable. The number of mechanisms that are used by a single nutrient to cause its effect, again, are countless. And when you start looking at this, and then you start realizing all the metabolic control mechanisms, how everything works together, I call it nature, if it says, it's just really extraordinarily impressive view of complications and complexities that we get caught up in. And rather stand back and just look at the beauty of the system. The beauty of the system. And it turns out every time we look for a part of that beauty, or the brushstroke in that art, if you will, it turns out every time it comes from a plant. And so I don't know, I get very excited about the concept about talking about the more holistic way of looking at this. And so diabetes, I think, was first mentioned here in this conversation. We tend to focus on just on diabetes, I guess, rightfully so. People have diabetes. But at the same time, in treating that, we're treating heart disease that Dr. Esselstyn has done so well, what he's been doing, and on and on and on.
Yeah.
I just find the concept fascinating.
What we have found too is when we treat a person with heart disease, and if they happen to be diabetics as well, the diabetes begins to reverse itself. The blood pressure will come down, the weight comes down. This is the magic of a plant-based whole food kind of a program coupled with exercise and some of the other things too, stress management and so on, giving the body an opportunity to utilize as many mechanisms as possible to produce healing. And the body actually is designed, it seems, is in a default position of wanting to heal itself if we put the right raw materials in. Any questions, any points on that?
Well, I think Dr. Campbell summarized it all beautifully in the title of his wonderful book called Whole, W-H-O-L-E. And it's a plea for, instead of looking at these individual molecules and their actions, and there is something to be, a value in that approach. But he says that people don't eat molecules of various nutrients. They eat food, they eat an apple, they eat rice, they eat beans. It's the nature of the whole food stream coming in that has its effect throughout the body. And that's where the focus should be. If they're whole plant foods that grew out of the ground, that have not been overly processed, that's what Homo sapiens with our plant-based digestive systems really ought to be eating, and most of these diseases will clear on their own. And so I'll be forever grateful for Dr. Campbell's beautiful vision on that.
Yeah, and let me share real quick. Think about this. We all know that when you do analyses, you do univariate analysis, but if you really want to explain as well as possible what's going on, you use multivariate analysis. And so to me, we have been so slow to recognize that applies to nutrition and to the practice of medicine.
One of the things that I'd like to just comment on briefly and let others reinforce it if they feel to do so. When I take the patient's history, I find that in these patients that I see for our cardiovascular seminar, when I take their history, it's surprising how many medications they're taking. But then even beyond that, the number of supplements. I had a patient the other day who was 20, taking 20 supplements. And I asked him, was it your doctor who prescribed these? Oh, no. I've done my own research and I found out about these supplements. So what I've begun doing over the last 4 months is, as part of the seminar, I have 2 wonderful articles from recently from the New England Journal and also the American College of Cardiology, where some really wonderful senior authors have gone on record as clearly indicating that really we were designed to get our nutrients from food. That's how it's done safely. And now, since from the regulation standpoint, the regulations are just totally gone with the supplement industry. You have no idea what they're putting into these things. And there is absolutely no hard data to show that they're beneficial at all. So I try to save money for my patients, because some of them are spending hundreds of dollars a month on these ridiculous supplements.
Yeah.
And I do use a supplement, though. I do use B12.
Yeah, sure. But you see, we're looking for the magic bullet, right?
That's right.
You look for the best doctor, you look for the best hospital, you look for the best ingredient, and then that will take care of it. It is intelligent self-care that we need to stress. And that only comes through education, motivation, and inspiration. And it's usually best embedded in the mind of a person when you do it in a group setting. Now, Dr. Esselstyn used to just do one patient at a time with his wife. Now he's using 18, 20 patients, because you develop supportive care there, which is and makes it also more financially viable, right?
Well, yeah. Also, it's doing it this way was. See, we used to have patients who would literally fly in either from overseas through Canada or through the United States to Cleveland. They'd have to pay for the flight. They'd have to pay for the hotel. Now, it's all done virtually. I mean, it's with this is what we're doing today by Zoom, and it's really very effective and much more efficient. And also, when you have, let's say you have one patient who signs up for you, you know that when you give the message that next to that patient is grandma and grandpa on either side, plus maybe their cousins and nieces who are getting a free ride, which is fine. I mean, that's, we're trying to get the word out.
Before we turn it over to Dr. Conrad and to Dr. Emanuela, I wanted to just briefly touch on the aspect of the COVID-19 virus. Are there some things that we can do from a lifestyle point of view that would strengthen the immune system to make us less vulnerable to this virus?
Yeah, I'd like to jump in here. Yes, we can. We can do exactly the same thing we're all talking about now. And we had some data on a very serious virus in China many years ago, the hepatitis B virus. And we got data, really robust data. Those who consume more plants form antibodies and don't get the consequence of the virus, namely liver cancer. Those who consume animal food is only, on average, about 10% of what we do in the West. Those are the people who retained the antigen, did not form the antibodies, and got the liver cancer. Now that's hepatitis B. That's a different virus, obviously. But there's also been another paper coming out recently in June, I think it was, a group out of New England, I forget who they were, but they actually, in a poll, found that those who are less susceptible to the coronavirus are those who consume a plant-based or pescatarian diet. And so that together with what we had with the hepatitis, but yes, this is a tremendous opportunity for us to sell this story, I think. Without, we can't be firm about, we can't be definite about this. Of course, we got to be careful. This is such a sensitive subject. But just from the standpoint, the evidence, we can say something. Yeah.
Well, I appreciate you sharing that. I would just want to share another thing. One of the very first things that came out to my attention in the U.S. Very early in this pandemic was the elevated risk of severe disease in those that had chronic disease. If you had hypertension, if you had diabetes, these kinds of conditions, they were much more frequently having to be put on ventilation and so forth. Of course, now we know there's better ways than the ventilator. So my point is, then why hasn't America awakened to the fact that lifestyle medicine is in the business of producing remission? So and ACLM is working more specifically on this, trying to call attention that lifestyle medicine is not something that should be in the background just because we have a pandemic. Actually, if we were to treat people that were at high risk, this is what I think we should have done if we'd been up to speed. Lifestyle medicine would have been used to treat the high-risk elderly patients to put their chronic diseases in as much remission as possible to reduce their risk of death and severe COVID. And we still need to do it because this, I don't know what everybody else thinks, but I'm not a virologist, but I don't think the end is in sight. I don't think we see the end of the tunnel yet on this pandemic.
Thank you very much. I think we're coming towards a point where we want to turn the last few minutes over to Dr. Conrad and Dr. Emanuela. Thank you very much for a very thoughtful and also a very energetic exchange of ideas.
Thank you, Hans.
Yeah, thank you, Hans.
Thank you, Hans.
Good job, Hans.
Thank you very much for everyone's input. Although this is a roundtable session and not a Q&A session, we have had a lot of questions coming in. And there's one question which is I'm actually going to ask you, even though it's not a panel discussion, but I'm just going to throw it in there because it's with regards to a health problem that is slowly becoming the #1 health problem in developed countries, and namely psychiatric conditions, specifically depression and anxiety. I'm pretty sure you have a lot of patients yourselves who are clinicians who have beside everything else, they have depression and anxiety. And we had a question coming in. Let me just load it up. And it says, are there studies that the whole food plant-based diet helps psychiatric patients also with their prognosis? For example, patients with depression and anxiety. What would you say to that, panel?
Well, we had a young lady, my daughter, doing her dissertation on this very question. Can the CHIP lifestyle program affect depression in the participants? And the answer was very clearly coming out. It was more effective than taking Prozac.
Wow.
Yeah, and if I might add to that, I have been collecting the BEC2 depression inventory at the beginning and ending of my intensive treatment program for, well, from the beginning. And I have found that the results are actually more change in the depression score than in the cholesterol score or the blood sugar score. I might have somebody that I have a typical drop, let's say, of 40 or 50 milligrams per deciliter of total cholesterol, but I'll have, and that might represent a 15 or 20% drop, but I'll have an improvement of 60% in the depression score. So lifestyle, I think, here's how I mean, again, I'm not a psychiatrist and I specialize in this, but I believe what I see happening is that when patients who have been struggling with lifestyle diseases, more and more medications, and they get depressed, they think there's no hope, they get into a lifestyle intervention program that turns things around. They feel better than they felt in years. They can't help but feel hope. It changes
Correct.
their worldview. It's very therapeutic.
Correct.
Just so that the person asking can take something practical away, can you recommend any books written by somebody who has written a book on lifestyle medicine plus depression or anxiety that they can try and buy on the internet?
Well, Dr. Neil Nedley certainly is known in the US for his depression and anxiety recovery program, and he has written a book. Someone help me. Depression, the Way Out, is that the title? Depression, the Way Out, I think is would be one I would recommend.
Okay, so Dr. Neil Nedley, Depression, the Way Out, look into it. As far as I know, Romania has translated about 3 of Dr. Nedley's books. So the listener might even be able to find it, and I think they will find that one in Romanian. Thank you very much. I have one last question, and that question will be addressed to Emma. Basically, I'd like you to tell us and the listeners what inspired you to devote your energy, your time, your resources, what you have to basically start the Romanian Society of Lifestyle Medicine and to launch this Congress. And maybe you can tell us a little bit about your story, how you got here.
Well, it's so hard for me to speak after these titans of lifestyle medicine were delighted us with so many information. I rather put me on silent to listen to you 1 more hour. But I will go and I will answer to your question, because I want the Romanian people to find out about my way, how I get these wonderful people to come together at this time talking about how a healthy lifestyle can save Romania. Well, I became plant-based while I was in med school, and I grew up as a physician focused mainly on healthy eating and with a strong desire for educating myself for shifting to more strong holistic approach of the patient. I felt that I would rather focus on patient education and prevention via a healthy lifestyle than on treating the illness after it already occurs. I got some weapons, let's say. I followed the nutrition study from T. Colin Campbell. I followed the CHIP program of Dr. Hans. I attended the rotational program at Barnard Medical Center at Dr. Neil Barnard's clinic, and I discovered how doctors can use lifestyle intervention in order to prevent, to treat, and often to reverse so many chronic diseases with way better results than the classical approach characterized by this polypragmasia as you were talking about tonight. I knew that I cannot practice medicine as I was taught before without addressing the root cause of these maladies. I saw with my own eyes how long-term health and well-being of the patient is treating with lifestyle approach with greater impact. And I was shadowing Dr. Loomis, and this literally changed my medical approach. Around half of the deaths in Romania are attributable to behavioral risk factors. 1 in 5 Romanians are daily smokers. Alcohol consumption is a major public health threat. Health spending in Romania is the lowest in the European Union. And the healthy lifestyle is the only way to reduce the general population health risk. So my desire to share the Romanian patients the revelation that lifestyle is the best medicine, the cheapest medicine, grew so strong that I started to talk everywhere about lifestyle medicine and its benefits. I founded the Romanian Society of Lifestyle Medicine, a professional medical organization to work as an umbrella for all the medical professionals, for the physicians, nurses, dietitians, trainees, coaches who are passionate for working together in order to empower the patients to take charge of their own health. Born and raised in Romania, I felt an urgent need to help Romanian patients find about a better way to handle their health through lifestyle medicine. And back in 2019, I met my mentor, Dr. Hans in Warsaw, and along with my team today with Konrad, Daniel, Joe, and many others, we start working together to organize this inaugural event. And I'm so happy that this is historical time for Romania, and I encourage all these titans of lifestyle medicine to leave for us a strong message before we close. And before I will finish, I would like to express my sincere appreciation for all of you who generously help us make this event come together to become such a success. I couldn't have this made it possible without all of you. Thank you so much. And I will leave the mic for Konrad to ask the titans of lifestyle medicine to leave a strong message for us. But before then, I hope that you enjoyed this panel of experts, and I would like to invite the participants to watch the next wonderful health documentary called Eating You Alive, directed by Paul David Kenmar Jr. and my friend Mary-Lee Jacob, starring with James Cameron, T. Colin Campbell, Dr. Esselstyn, Dr. Neil Barnard, and I will put me on pause, and thank you once again for everything. You are wonderful. Thank you.
Thank you very much, Emma. Just before I ask each panel member, so please get your cogs rolling, a one-liner that you'd like to pass to the Romanian public. Just before I ask you to do that, dear participants, I'd like you to know that we have gotten your questions. We will try to get some of the Congress speakers to answer them. Obviously, we can't do another panel discussion. What we will try to do is get answers for you in writing. In the conference platform at the top, you have a button that says Q&A. We're going to try to upload your questions and answers once we get the answers for them. In the next few days, please check that section of the conference platform to see if we've managed to get an answer to your question. As I said on our Sunday session, unfortunately, we are not able to answer everything. We do plan to stick around and not disappear after this Congress. So hopefully, if we can't answer your questions now, at smaller regular events, which the Romanian Society of Lifestyle Medicine would like to organize, we'll be able to answer your questions. We would like to start membership subscriptions as well once the Congress is over. So anybody interested in becoming a member of the Romanian Society of Lifestyle Medicine, please get in touch with us. Give us a few days, 1 or 2 days after the Congress is over, to get over this very hectic period and for things to settle down, and then we can start processing the applications that you're going to be sending in. Thank you very much, everyone. The last words then will be from our panel members. One-liners, please, for what you'd like Romanians to know, starting with Dr. Campbell.
Eat plants is good for personal health as well as our planetary health.
Thank you very much. Dr. Esselstyn.
Yes, it's about 21 years since I retired from surgery. And I find myself more optimistic than ever about what could be the seismic revolution in health. And the seismic revolution in health is never going to come about from the invention of another drug, a pill, or a procedure, or an operation. The seismic revolution will come about when we in the profession have the will and the grit and the determination to share with the public what is the lifestyle, and most specifically, what is the nutritional literacy that is going to empower them as the locus of control to absolutely annihilate chronic illness. And I want to say thank you to Conrad and Emma for this kind invitation.
Thank you very much as well. Dr. Kelly.
Yes, thank you also to you and Emma for having me and being part of this. I just want to say this, that to my clinician friends, physicians or non-clinicians, that lifestyle interventions possess a dosing effect, and learn and use the appropriate therapeutic dosing for the patient and the disease.
Thank you very much. Dr. Klepper.
Again, thank you for the invitation to be part of this wonderful conference. I wish you great success in all your endeavors. I had a professor in medical school that said people don't get diseases, they earn them. Meal by meal, argument by argument, drink by drink, cigarette by cigarette. Well, the good news from lifestyle medicine is that people don't get glowing health. You can earn it. Healthy plant-based meal by healthy plant-based meal, by loving interaction, and doing good works and being grateful. That's how you create a healthy body and a healthy life. So earn good health every day, and that's exactly what you're going to inherit.
Thank you very much. Emma, if you have something for the Romanian population.
Well, I will close, but not before to give Dr. Hans the last word. I will close to say the time for lifestyle medicine has come for Romania, and I will do everything I will be able to bring this free pill for every malady we have linked to this unhealthy lifestyle. Thank you so much.
And last but definitely not least, our keynote speaker, Dr. Deal, please.
Well, thank you. It was a very exciting endeavor for all of us to lay the foundation for what Dr. Esselstyn calls the needed seismic revolution in the medical health field. My points are these. Health is largely a matter of choice, not chance. Number one. And number two, it's habits that drive health, and it's habits that drive disease.
Thank you very much. Dear participants, we hope that you've been able to get at least one good idea from tonight, but I think it's practically impossible to only leave with one good idea from tonight's session. Thank you very much for being with us. We'd really like to offer you again the documentary. Please enjoy it. That's coming up after this. And wherever you're watching from around the world, I wish you a good morning, a good afternoon, a good evening, and good night. Goodbye, everyone.